Welcome to the Warrior One Spine webinar with our special guest, Dr. Pascal Breton. Your hosts today are Drs. Ed Quirk and Yuri Chupa. Go ahead, doctors.
Hey, guys.
Hey, everybody.
So I just wanted to start off by just thanking everybody that are attending today. We actually have just over 100 people across Canada and in the States that we're going to be on today, which is really, really awesome. You know, we're very thankful for you guys to be here because we know that there's a lot of different platforms in chiropractic, and we all know there's a whole bunch of different agendas in chiropractic, and we're just grateful to have you guys here because, you know, what Yuri and I have been about in the past 20 whatever quarter century is all about chiropractic. And you know, just this week I actually got a couple of invites for different webinars. This is a one that says that post-surgical rehabilitation for adults and the interventions that are effective, how surgical rates of low back pain are increasing, and how many patients treated surgically require post-surgical rehab. And then they're going to go over some of the interventions that are effective. Not exactly sure whether the chiropractic's in there or not, but whatever. But like, if you're a chiropractor that loves rehab, that is awesome. I got another one here that says, you know what, there's a webinar on interactive rock tape. Actually, sorry, it's an interactive rock tape webinar. And, you know, nothing against rock tape, okay? If you're a chiropractor that loves rock taping, that's awesome, okay? I think there should be a place in our profession for that. But what we're about is spinal reconstruction and corrective chiropractic. And what Warrior One Spine that we started just a couple of weeks ago, what we're gonna be all about is corrective chiropractic and spinal reconstruction. Why? Well, if you know, we were just on the pre-call and Pascal was asking me about some of our artwork here in the clinic. Yeah, those are canes, and those are actually forms that Jody used to wear before coming out of her wheelchair after her accident. And so that's what we're all about. We're all about the why. The why is changing people's stories. The why is changing people's lives. And that's what we've been about for the past 25 years. That's why we went to 2,000 a week so quickly. And that's what these webinars and these coaching calls are going to be all about. And just a little housekeeping before I pass it over to Yuri is that many of you have already asked and emailed us about whether this is going to be recorded and whether you'll have access to it. And the answer is yes and no. And it's truly a yes or no, but the first thing you should do during this call, or actually right after the call, is we have a new Warrior One Spine YouTube channel. So if you want to go to the channel and then hit subscribe, okay? So you'll see that's the red square for those that don't do a lot of YouTube, including myself, the red square. And then once you hit the red square, ring the bell, okay? The bells are going to allow you to get notifications. So this way that anything that gets posted up on the Warrior One Spine YouTube channel, you'll get you'll get the notification. In addition, if you're on this call now, you'll receive invites to the webinars and to the coaching calls and stuff like that. But some of the calls and some of the webinars are going to be private. And that's why we want you to subscribe to the YouTube channel, because that way we're going to be strategic about this too. Not everybody needs to see what all of our content. So what we're going to do is this is going to allow us to privately invite you to view some of the webinars and some of the coaching calls that are going to be for your eyes only. So that's all I had to say. Just remember, hit subscribe and then hit the bell afterwards, and you'll be able to stay in the loop with the invites and the private viewing of some of the video. Yuri?
Awesome. Yeah, so super excited to have Pascal on. I'm going to introduce Pascal. Many of you have already heard him speak. He's been speaking with Warriors for, I think we're trying to decide if it was 4 years or 5 years. And you know, one of the biggest things coaching chiropractors for the last 20 years and my own experience of being in practice for 35 years is that, you know, your outcomes, our outcomes as chiropractors are best when we have faith, confidence, and belief in what we do. And so I think that's the bottom line with what Pascal brings us. If we understand the research behind what we're doing, then our communications with our patients completely change. And I think it's super important, and you guys will probably agree, that if we have a patient in front of us that needs corrective care, but we can't communicate that properly, or we're not passionate about that communication because there's some doubt in the back of our minds, then that patient may leave and never start that care, and they're going to degenerate and they're going to end up having surgery or worse. And so, you know, that's what this is really all about. And also, you know, chiropractors, we're in Canada anyways, we're on the brink of getting very restricted on how we can use X-ray. And so bringing chiropractors together, warriors and non-warriors alike, that have a passion for reconstructive care and really require really need the X-rays for confirming what we're doing. So if you're not a warrior, you're on this call, that's awesome. We need to collectively come together and make sure that we can fight for the rights that we have so we can treat our patients properly. So super excited to have Pascal Breton with us. Pascal is, he's a Canadian representative for Degeneration Spinal Orthotics. His company is Spinal Health Distributors. He'll give you some more details about how you can order products that help you correct the spines of your patients after this is all over. Also, just as a quick, the chat is off right now, and we will turn it back once Pascal's presentation is over. There'll be some Q&A. We'll open up the chat, and then we'll get at it from there. So Pascal.
Thanks, guys. Can everybody hear me? Thumbs up if you can. Beautiful. Excellent. I see, first of all, thank you to Drs. Ed, Dr. Zuri, and all of the Warrior Docs for having me back on. I'm always humbled and grateful to be able to share these Warrior webinars with you guys. I absolutely love this stuff. I'm a bit of a spine geek, and so I'm glad when there are doctors who are willing to listen and apply some of this stuff in clinical practice to always get, again, as doctors both Ed and Yuri mentioned, better clinical outcomes, better outcomes from our patients, and have them stay on long term, because that's the goal, right? We know that we get our best results over time, and patients do the best over time. So I'm super happy to be here today. I was just looking in the chat on the side here, or the names, and I see a lot of familiar names from previous years. So those docs who have been on year after year and following, thank you for being on and paying attention. And, you know, if you've been on these for a long time, they're always building on each other. So it's going to make more sense to you if you've seen the previous webinars. If you're not a Warrior Doc or you haven't seen the previous Warrior webinars, get in touch with Drs. Ed and Yuri both, and let's get you access to those previous webinars so you can have that foundation and continue to build. So some of the concepts that we talked today about are going a little bit over your head. I'm not going to dive into detail about a lot of the measurements that we're going to discuss because we've covered them in previous webinars, okay? So if some of the stuff is 37,000 feet, that's okay. The big idea today is to understand that spinal surgeons share a lot of the same interests in correcting the spine as we do, okay? So let's dive into this. So first of all, I want to give credit to where credit is due. So Dr. Evan Katz, he's a chiropractor in Colorado. He does a lot of work with patients who are in car accidents, personal injury cases. And so a lot of this research I grabbed from his website, which is professionallyintegrated.com. And so he has a service. One of the services is free. He has a few different levels of paid service depending how much detail you want on these articles. But he is someone that combs this research. He goes through this research and he has it in this really nice database format that you can follow. And it is obviously geared towards injury stuff in the US, but the reality is it applies to everything that we do as corrective care chiropractors. So I want to give him credit because, you know, I wouldn't have known about these articles had it not been for him. He's a CBP doctor. And if you were on the webinars last year, he was the one that did the MRI study. He rented out a private facility himself and, you know, put dental rolls under patients' necks to see how well the blood flow to their brain improved while they were in the MRI machine with a dental roll under their neck. Furthermore, Evan Katz has volunteered to be an expert witness in this battle against the BC board to protect our x-ray rights, right? As we all know, there's some dimwits in our profession who unfortunately want to remove our rights for the biomechanical assessment of the spine, saying that there's no science or data to support the fact that we should be taking x-rays for biomechanical reasons and reconstruction of the spine. And this is likely some of the stuff that Dr. Katz is going to be using to battle against these chiropractors who are naysaying the benefits to reconstructive surgery or reconstruction of the spine, okay? So again, let's get into this. So some insurance companies, providers who were saying we shouldn't be doing reconstruction, that we should only be adjusting people for pain. And these surgeons are getting compensated a ton of money to put curves back into the spine, to fix the spine, things that we can do for an absolute fraction of the cost with the added benefits of obviously getting these patients adjusted. So understanding this science, understanding this, and taking some notes today and putting some of these notes in your daily soap notes is not only going to help you be an expert, but help you, like Dr. Yuri mentioned, communicate to your patients to keep them on long term. So let's get into it. We're going to cover 3 articles today. This is only the tip of the iceberg. Again, if you start diving into this, there's article after article, because this is truly an area of extreme interest, and it's a hot area in the research right now for spinal surgeons, okay? So I cherry-picked 3 articles that I wanted to go through with you guys, and these are not just mom and pop journals, right? NEUROSURGERY, Journal of Spine Surgery, Journal of Neurosurgery Spine. These are top-tier journals from, what's considered in the spinal world. I wish it was chiropractors who were at the height of the pyramid or the top of the food chain, but the reality is it's neurosurgeons, right? Spinal surgeons. And this is some of the stuff that they are saying and that they are researching. The same things that CBP has been promoting for the past 35, 40 years, these spine surgeons are now taking an interest to do the exact same things that we are trying to achieve with our patients, okay? The first article, in a nutshell, they are saying lordosis after fusion gives better outcomes. What these surgeons were looking at was when they do a discectomy fusion, right? So these patients come in, they have neck pain. For whatever reason, they are deciding to do surgery. Oftentimes, it's patients who do what, they'll consider 6 weeks or 6 months of correct conservative care. These patients fail conservative care. They're still having neck pain, or, they might have some disc issues, disc problems. So they deem that they're candidates for cervical surgery. And so these surgeons were looking as to whether or not the shape of the allograft that they put in between the bones would change how much curve they could put into the neck, and would change the outcomes for these patients long term. Okay, so they were comparing what they call lordotic allografts versus parallel allografts, which means absolutely nothing for us. So it's a detail that we're not concerned with. I'm just explaining what these surgeons were doing. And they were, again, the most important part was looking at what was that result in terms of curve correction, and what was the result in terms of patient outcomes when they were using these different types of allografts to fuse these patients, okay? So these are just some of the highlights from the article. They're saying, although it is generally accepted that the physiological sagittal balance is important for normal function of the spine, whether maintenance and improvement of the cervical and or segmental lordosis have an effect on clinical outcomes after surgical spine surgeries remains to be proven, right? So this is back in 2011. This is, some of the hypothesis. This is the questions, the introduction in this article stating, is there a benefit to putting the curve back into the spine? Is there a benefit to looking at the alignment of the cervical spine? What these surgeons did, right? They did assessment preoperatively and postoperatively. They looked at CSA, which stands for the total curve in the neck, and segmental sagittal alignment, what we would call intersegmental subluxation. So they were looking at the curve between individual bones, and they were looking at the curve, the total curve in the spine, right? Now, I'll just take a minute. And the reason I highlighted this in yellow is because these surgeons took an x-ray before they're going to work on the spine, and they took an x-ray after they worked on the spine, right? Do you think these surgeons are being reported to their boards? Do you think there's a battle within the neurosurgical profession where some of their colleagues are trying to get x-ray rights removed so that they cannot x-ray their patients after they've done something? Absolutely ludicrous to think that, a surgeon or any health professional that's going to be working with the spine doesn't want to see, number one, what they're working with, and after their intervention to see how well did my intervention work, and did this intervention correlate with long-term health outcomes on our patients. This is no different. This should be absolutely the very same thing for us. We want to see what we're working with once we're done our work, or incrementally throughout our work, because we're never done our work. Incrementally, we should be checking up to see how are these patients doing, what does their spine look like, and does that correlate to how well they're doing? Okay. These surgeons measured the spine using the posterior tangent method, which is exactly the same things that we do with our patients. Okay. Sec here. Where's my mouse? Sorry, guys. Give me one sec here. All right, so lordosis after fusion gives better outcomes. So again, what these surgeons were saying here is it was determined that the maintenance of or change in SSA, stands for segmental sagittal alignment towards lordosis, was an important factor responsible for a higher degree of improvement in clinical outcomes after single and multi-level fusions. In our investigations, patients who had the change in SSA towards lordosis demonstrated, sorry, let's go back one there. Sorry, guys, having a little technical difficulties with my mouse here. They were saying the patients that had the change in lordosis in their single and multi-level fusions had better improvements in neck disability and overall quality of life scores. So what does SSA mean? Again, it's segmental sagittal alignment. So they're looking at the alignment between two individual vertebrae. So for instance, we could use C4 and C5, right? They're saying the patients that had a change when they fused them towards a lordotic position had better results in terms of neck pain and quality of life scores, right? And in total conclusion for this study, they were saying that maintaining a consistent or improving the segmental sagittal alignment was related to a higher degree of improvement in clinical outcome scores. So their hypothesis at first, they were looking as to whether or not it was important to look at segmental lordosis and total lordosis and look at the alignment of the cervical spine. And in their conclusion, maintaining a consistent or improving the segmental alignment is related to a bigger degree or a higher degree of improvement in clinical outcome scores, right? And I want you to look at the words that they chose in the earlier statement there. They mentioned that they demonstrated a significantly higher degree of improvement in clinical outcome scores. So they're not saying it was a moderate change. They were saying it was a significant change, okay? This one is a second article. This is out of the Journal of Spine Surgery. And this was a review article where they were reviewing the literature to say, you know, as surgeons, do we know enough to create successful spinal surgeries? Should we be looking at curves? Should we be looking at alignment and positioning? Okay. And so this is very similar to what the Harrisons did at first when they were looking at putting a curve into the neck. At the very beginning, when they came up with their cervical models, they were thinking that everybody should have that ideal 42-degree arc in the neck, right? And as time went on, they started to realize that, well, maybe it shouldn't be a 42-degree curve for everybody. Maybe there is some genetic variability. Maybe there are other things that we need to consider and not just put a curve back into the neck. So that's what this article largely stated. Okay, so here are some highlights from the abstract. Over the past decade, there has been growing interest in the sagittal alignment of the cervical spine and its correlation to clinical outcomes. It is now known that the cervical lordosis is not universally physiological and should not be pursued in all patients undergoing surgery. Okay? Rather, it is increasingly understood that it is how these angular parameters, lordosis or kyphosis, interact with translational parameters that is reflective of overall cervical spine and whole spine balance, which in turn impacts patient outcomes, okay? In simple English, they're saying that we can't just simply slam a curve into a neck. We have to understand translational parameters, which again, last year when we did our cervical reconstruction, we talked about translation and how when the spine shifts forward, backwards, these shifts in the spine come with biomechanical changes or compensatory patterns. And we have to look at those patterns. We can't just fuse someone in a bad position with a neck curve. Like if their head is way forward and they got a really strong kyphosis, if I put a neck curve in, you know, that's better, but it's not a great outcome. There are other things to look at. People that have very low pizza angles or very shallow thoracic inlet morphology are never going to have great curves. And we have to be very careful that we don't put too much curve into their neck. We want to fuse their neck, or we want to achieve the proper alignment for that patient's spine. So what these surgeons are saying is it is not just putting a curve into the neck, it is multifactorial, and we have to understand the biomechanics, the dynamics of the spine as a whole before we do our intervention. And the same goes for us as chiropractors. We can't just simply try and ram a curve into the patient's neck. We need to look at translational parameters. We need to look at the thoracic kyphosis, the lumbar lordosis. We need to look as to whether this patient is shifted forward, backwards. Is there degenerative changes? And so all these things need to be taken into consideration to understand what that patient's normal should be and what we are looking for in terms of our reconstructive outcomes. Now, here are some of the x-rays that they had highlighted in this article. Now, we don't have a full background on this individual patient, so we're not going to judge the spine surgeons and say they did something that should not have been done. But what I want you to notice is, yes, this patient had a cervical kyphosis. Now this patient has a lordosis, but at the expense of what? 1, 2, 3, 4 screws, 2 metal rods into this patient's neck, loss of mobility, adjacent segment degeneration that's going to happen for sure at C1, C7, C6, right? And so yes, this patient now is probably better off because they have a lordosis in the neck, and this patient will fare better than maybe they did with this kyphosis. But how? How can someone argue that if this is reasonable and acceptable for a patient to undergo a surgical intervention like this, that it is not reasonable that this person undergo, multiple stages or years of corrective chiropractic care to try and achieve and maintain a lordosis in their neck to not have to have a 4-level cervical fusion, right? Again, completely ludicrous that we are that we're judged or that we have professionals in chiropractic who are trying to remove these rights from us and are arguing that this is not valid. It's crazy. Sorry if I'm getting a little fired up and stumbling on my words. This topic gets under my skin. So some of the highlights of this article, again, over the past decade, there has been growing interest in the sagittal alignment of the cervical spine and its correlation to clinical outcomes. Early studies have focused on mainly achieving sagittal spine balance as determined by the sagittal vertical axis. So what they were saying was, at first, they weren't necessarily looking at curves. They were more interested in just fusing a patient in proper spine balance, okay? And again, we looked at this in the cervical spine, and I've gone through the sagittal vertical axis with you guys. We just use the terms anterior translation, posterior translation. But for a quick overview of what they mean by SVA is, when we're looking at the sagittal profile, so this is a sagittal profile x-ray, the vertical axis is going to be a reference point. So we could use, oftentimes they're going to use the sacrum. So they can put a dot somewhere on the sacrum, anterior, posterior, whatever they choose for that study. Okay. So in this case, let's use posterior, superior aspect of the sacrum. And I draw a vertical line up. Now the reference points from there, sometimes it's C1, sometimes it's C7, sometimes it can be T1, depending on the study, depending how they x-ray and what they see. Now, what they're looking at, what they mean sagittal vertical axis, is they're measuring the distance in which the spine is shifting forward relative to that vertical reference point, okay? And we know there are boatloads of studies that show that the larger the distance between whatever reference bone they choose up here in the spine and the pelvis, the larger that value. So in other words, the further forward this patient translates, means a more positive SVA equals bad outcomes, right? Higher pain, higher disability, more fractures, more organ problems, right? More general nervous system dysfunction, more falls, and a higher rate of death, okay? So surgeons know it's important to address this with cervical fusions. Now they're saying, should we also be considering what the curves look like and how do we implement curves with sagittal alignment when we're doing these surgeries? And I would say, I don't know about you guys, but I think this patient probably should have went under chiropractic care before going for this surgery. All right, so the other thing that I love about this, all right, so we have Dr. Pierre Cote who writes this report or comes up with this study for the BC board saying that there is no evidence to support that corrective care, or there's no evidence in the literature, no scientific literature that supports doing corrective care and patient outcomes. So when he did his literature review, they did not use anything from the CBP library, none of the 240 plus studies that CBP has done. What's really interesting, though, is that a spinal surgery review article actually did look at some CBP work, and they did look at the Harrison's work. And so some of the stuff that they're discussing in this article, they actually reviewed CBP line drawing. They actually reviewed CBP modeling and the outcomes of care based on some of the work that we're doing as corrective care chiropractors. So, for those chiropractors that are saying that science is not valid, well, again, I'm calling BS, because now you've got a surgical article that's actually looking at the measurements and stating that, yes, this stuff should be considered, and yes, we should be using this stuff, okay? So here are some of the excerpts again from this article. A correlation has been reported between patients with acute and chronic neck pain and reduced cervical curve below 20 degrees compared to asymptomatic individuals. Another study showed that global cervical alignment correlated with health-related quality of life indices. That alone, even outside of putting curves in, how can you know what the alignment of the cervical spine looks like without taking an X-ray, without working on it? And so we know that the alignment of the cervical spine is directly related, and that has been stated and proven over and over, to the health-related quality of life indices. A kyphotic cervical spine places the neck musculature at more strain when supporting the weight of the head, with increased pressures on the intervertebral discs, resulting in accelerated degeneration and worsening deformity. This finding is also highlighted in several other studies in which a kyphotic cervical spine predisposes patients to an increased risk of what? Developing pain, great, right? But what we're more concerned about, neurovascular deficit, including cervical myelopathy. That is a beautiful definition of subluxation right there. It is generally accepted that in patients undergoing cervical fusion surgery for a variety of indications, fusion in kyphosis, whether regional or global, should be avoided, as it is thought to lead to what? Increased rates of segment degeneration, adjacent segment degeneration, meaning the segments above and below will start to degenerate and degrade if the spine is fused in a kyphosis. And even if it's not fused in a kyphosis, if a kyphosis is just left in a non-fused neck, you're going to see more rates of degeneration throughout the cervical spine. That's what the previous paragraph had said, okay? Now, restoration of the cervical lordosis allows optimal distribution of weight to the posterior column of the cervical spine and more efficient energy expenditure by the neck muscles. Mic drop. A commonly used translational marker for the cervical spine sagittal balance is C2 through C7 SVA. Again, what we discuss as anterior head translation. So this author here found that patients undergoing cervical spine surgery, their preoperative sagittal alignment correlated to the degree of reported disability. In other words, the higher the C2 through C7 SVA, aka the further their head translates forward, they had a higher level of neck pain or disability, okay? While higher values of cervical lordosis, so the more curve they had and the more slope they had at T1 relative to vertical. And if you guys remember from last year, T1 slopes are referring to the amount of kyphosis. In other words, the more lordosis they had and the closer their T1 slope approximated their normal thoracic kyphosis, they had lower neck disability scores. Interesting, right? So if we decrease anterior head translation, right, and I drew the anterior head translation as I taught it to you guys last year, and we increase cervical curve, patients have lower rates of neck disability. Beautiful. Conclusion. Cervical sagittal balance is undoubtedly a vital concept that must be considered with surgery to the cervical spine. Patients with preoperative cervical kyphosis with sagittal imbalance are known to have worse outcomes post-operatively. Okay, let's rephrase that conclusion in a chiropractic model. Cervical sagittal balance is undoubtedly a vital concept that must be considered with chiropractic care to the cervical spine. Patients pre-care with cervical kyphosis in sagittal balance are known to have worse outcomes, especially if we leave the kyphosis in their neck post, pain care. Last article we're going to discuss, fusion to improve the lordosis. I included this article because I wanted to show you that, the rates of correction that these surgeons are excited about pale in comparison to what you guys are doing every single day in your office. I can guarantee you that probably every single chiropractor on this call will see necks significantly worse than this and will be able to get better results than this patient could ever get in a cervical fusion. Okay, so these surgeons did the same thing. They call it an anterior discectomy fusion. So, they pull out a piece of disc material and they fuse two vertebrae. And their goal, these surgeons, their goal was to try and put a curve back in because, as they state here, right, that this type of surgery can be used to correct cervical kyphotic deformity, which is the most common cervical deformity and is often performed using lordotic interbody devices. Worsening of the cervical sagittal parameters is associated with what? Decreased health-related quality of life. There it is again, boom, over and over and over. The radiographic measurements that these surgeons use were focal lordosis, or what the other article had referred to as SSA, okay? What we refer to as the curve between two segments or intervertebral subluxation. Disc height, which we don't typically measure. I don't measure in my office. I just look objectively on x-ray to see if there are differences in disc height, if there are signs of degeneration. C2 through C7 lordosis, so total curve. They did C1 through C7. We don't. We just use C2 through C7 because it's easier to recreate. And they looked at the T1 slope relative to vertical, which we discussed again, is that indirect measurement of thoracic kyphosis. And lastly, C2, sagittal vertical axis, or anterior head translation. So those same four variables that we've been taught or that we discussed last year that we measure over and over to understand what's happening with the patient's neck. Now here are their results, okay? So their pre-surgical curve was 9.66 degrees. At 1 year, this is what they state. The C2, C7 lordosis significantly improved at 1 year by a whopping 3.46 degrees. This is the kind of change that you can get in about 10 sections of laying on a dental roll, right? Without the complications of surgery. Yes, they had a nice intersegmental change. They took, a vertebrae that had zero curve, like this would be a vertebrae that's has 0 degrees of curve. And at 1 year follow-up, they said they averaged about 6.5 degrees, which is pretty close to the normal or ideal value of 8 degrees. So, intersegmentally, that's a great change. Globally, they get 3 degrees of change. Great. I'm happy that these patients are doing well. But again, we see necks like this day in, day out, and we could do this stuff for our patients at a fraction of the cost without any of the effects of surgery and all of the functional and neurological benefits of being adjusted. All right. I'm going to read this last paragraph from, again, this article, because this simply supports chiropractic through and through for any docs who are doing this type of corrective care, okay? So listen to what these docs are saying here. The ability to create and maintain cervical lordosis is an important step in optimizing overall cervical alignment and thus increasing the probability of obtaining excellent short-term and long-term outcomes. Again, another statement that completely supports what we're doing and what we are trying to achieve. How can someone negate something like this? I mean, this is 3 articles now stating this over and over again. Due to the increasing recognition of cervical sagittal alignment as an important indicator of cervical deformity, osteotomy techniques have been developed to gain lordosis and thereby improve cervical sagittal alignment. However, these lower cervical and upper thoracic 3-column osteotomies can result in significant complications. No kidding. When we cut open a cervical spine, there can be complications. So it would be best if each and every ACDF, so anterior fusion procedure, was performed in such a manner to minimize the likelihood that significant deformity will occur with time. In other words, they're saying when you fuse the neck with these anterior fusions, try and fuse them in a curved position, not a kyphotic position, so that these patients don't have to do revision surgeries later on, right? Osteotomies to decompress the spine and to try and put the curve, back into the neck, because those patients do worse if they're not fused in a proper position. So achieving this goal will decrease the need in the future for complex, expensive, and dangerous procedures in those patients who initially only require 1 or 2 level cervical fusions. Let's reframe that conclusion again. Achieving this goal will decrease the need, achieving this goal meaning cervical lordosis. So achieving a cervical lordosis will decrease the need in the future for complex, expensive, and dangerous procedures in those patients who initially only required corrective chiropractic care. Can I get an amen? So how do we do that? Exercise, adjustments, and traction, right? Exercise, adjustment, and traction, the EAT protocol. Exercise with our prolordotics, traction, laying on dental rolls at home or in our office, and adjustments, the magic that you guys are making happen in your office every day. And with that kind of protocol, here's an example of what we can do over the course of a year without surgery, right? So here's an 8-degree curve, one of my patients, to a 25-degree curve by simply following that protocol over the course of corrective care with 1 year. 17-degree curve improvement, no surgery, no complications, right? So, this is the last slide I had for you guys in terms of x-ray correction. So I hope that, you guys are going to take away this message here. We're going to agree with the ACA, right? Choose wisely. Let's not take x-rays and only adjust our patients 4 times for pain, because there is no benefit above that, right? I hope you guys know I'm being facetious. What is wrong with some of the people in our profession? So again, thank you for being on this webinar with me. Here is a 10% coupon code for any docs that are purchasing Deneroll products. WQ121, and it's valid until April 6th, 2021. This is the site where you can buy those Deneroll products. And again, guys, the reason to use these products if you're doing corrective care and not using something like an Apex roll or some sort of posture strap is the investment back into yourself. Why? Because these products, chiropractors like Dr. Evan Katz, Dr. Deed, myself, we are the ones that are trying to put out research and have a vested interest in supporting correction-based or subluxation-based corrective care. Evan Katz has volunteered to be a witness. Dr. Deed Harrison is involved in this battle in the BC X-ray rights, right? I have volunteered my time in anything that I can do to help as well. I can guarantee you that the Apex roll or these posture straps, they haven't called up any of these BC chiropractors to say, hey, where can I give money and can I volunteer my time to help out? So again, support Deneroll products because they're supporting the ones, or they are the ones supporting correction-based chiropractic care, okay, or subluxation-based chiropractic care. Those are my 2 email addresses to get in touch with me, guys. And then my YouTube channel, which has videos on how to use some of these Deneroll products if it's totally new to you. And then just reach out to me at this email because I'm not very good with checking that one. All right. Thanks, guys. That's all I had for you. Let's open it up for Q&A. That's
awesome, Pascal. Get this, I got a really cool story. So about 10 years ago, I'm doing master ski racing at Tremblant, okay? Yeah. And I'm in this group, and there was this guy in the group. So I have 2 kids, and they were really, well, they still are really awesome skiers. But back then, this other guy had a younger guy. So he always been trying to pick my brain and, how to kind of maneuver ski racing and going as far as you can. So he'd always try to get on a chairlift with me. So anyways, one day we're going up the chairlift together, and he's going, like, what do you do for a living? And I said, oh, I do spinal reconstruction. I'm a chiropractor. We specialize in getting curves back in the neck and stuff. He goes, really? He says, how do you do that? And he, we talk about the adjustments, the schedule, the elasticity of the ALL and the Deneroll and all that. And he's going, really? He goes, you know what I do? I said, no, what do you do? He says, well, at the Montreal Hospital, I'm a spinal surgeon. I specialize in actually cervical spinal surgeries. And I'm going, are you kidding me? He goes, I said, so do you take into account, the 42 and, and he's going, no, but we should, because, and then it just blew my mind just to have this real professional to professional conversation that I can't even have with most chiropractors in our profession. And just realize, guys, we are the specialists. The more you understand that we are the specialists, things explode. Nobody else can do what you are doing, okay? And I'll come back, one more thing before I pass it off to Yuri too, is back in 1997, I picked up this book, okay? So it's Ruck's book, back in 1997. And when you start to realize what you see on X-ray every single day, and they do side by side, so they'll do X-ray, and right beside the same person, they'll actually show you what the spinal cord is going. It'll show you the stenosis starting in a phase 2 or at the end of phase 1 and progressing to a phase 4. So that's why phase 1s are serious. That's why phase 2s are serious, phase 3s and phase 4s. It's all serious, and you guys are the specialists, okay? So pick up this book again and just look side by side what we see every single day. And there is no way that we're giving up X-ray. It's like we're going to fight this to the nth degree. Okay, there is no way. And the more we get people on this, one of the big things is having, coaching, Yuri and I coaching, is just having chiropractors fall in love with what they do and who they are, meaning that, is that really possible? Can we really get that curve back? Yes, we do it all day long, every day. And we've been doing it for a quarter century. Yuri?
Yeah, awesome. I don't think I have a lot more to add there other than, let's just open it up for some Q&A. If you guys have questions for Dr. Pascal, if you have a case study that you're working on, just fire them out and we can take a stab at them.
Oh, one more thing too is that Warrior One Spine Instagram, what I want to start doing is send me in your pre and post x-rays with the stories of, life transformation. I'm going to start posting it on Instagram. So we're going to have a whole bunch of pre and post stories.
It's an awesome idea.
All right. So Sandy, how do you want people to engage?
If you have a comment or question, please click on the raise hand button. I will advise when it's your turn and you'll be able to unmute yourself.
Hi, can you hear me?
You bet.
Hi, thank you, Dr. Pascal. That was really, really amazing. I have a question. There was reference in there to cervical kyphosis and increased risk of cervical myelopathy. And I'm just thinking of a few patients that I have that have a kyphosis in varying stages of correction. And now that I think about it, like some of them have multiple sclerosis diagnoses. And I'm just wondering, like, do you have any other specific references or have you seen anything that makes a direct connection there that shows the changes for people with MS? Like, just because some of them are really hopeful in their care and others are not hopeful, and they get stuck with that diagnosis and they can't see past it at all, no matter like how much we can instill the power of what we're doing, like with their spinal correction.
For sure. Yeah, no, I wish I had. It's funny because I have an MS patient, almost exact scenario. And, I was politely trying to ask her if she wanted to, do multiple rounds of corrective care and if I could publish this and do a case study for research purposes, because as far as I know, there's nothing for MS. And, I think there's absolutely going to be a link there between what's happening in the cervical spine and the myelopathy, but I don't know if there's any MS specific research articles that anybody has done where they've done curve correction with improvements in MS patients, unfortunately. The other things I've heard, though, again, like Dr. Katz and Dr. D talk about the different research articles where they show the kyphotic neck. And the biggest thing that happens in the kyphotic neck is the central cord moves anterior, right? So it's pushing against the PLL basically, or the back of the vertebral bodies. And obviously the stronger the kyphosis, the more stretch, the more compression there is. And so from what I understand, part of the degeneration in the cord at those segments is because of the increased pressure where the cord can literally butt up against the back of the vertebral bodies.
Okay, wow. Yep, thank you very much.
You're welcome. Thank you for being on.
Great, thanks, Dr. Barron. Next is Dr.
Thank you for that. That was just so amazing.
Awesome.
It gives a bigger level of certainty to and credence to what we're doing, those research articles. Yesterday, I did have a new patient who had spinal surgery anteriorly on his at a C5 area. I haven't seen the x-rays yet, but I'm wondering in terms of indications or contraindications for using adenorol, or I haven't even looked at, anything about his, thoracic kyphosis. I'm just wondering what I would be able to expect or where things could be placed. I know that isn't what this is about, but I'm wondering at some point if we're gonna do that, because I don't want to do anything that's gonna, cause more issues than what he already went through.
Right. Well, just understand that once it's fused, I mean, you got bone in there with metal plates, that segment is not moving, right? There's no movement at C5 anymore. And just like those articles I was presenting showed you, if there's any imbalance, right, outside of that segment that's fused. So let's say there's lacking curve at the segments above, or there's still anterior head translation, the more displaced or subluxated those other segments are, the more they're going to break down. So as a matter of fact, yeah, you want to do everything you can for the segments directly above and directly below that fusion to put them back into their normal position. So let's say if the fusion is C5-6 and, 2, 3, 4 are bad, could you use a small cervical dental roll above the fusion? Absolutely, I would do that. But always in a case where you're uncertain or where there's something like a contraindication, which a cervical fusion would technically be, I always x-ray them on the dental roll to have that clinical confidence that it is pushing in the right spot, like in other words, putting the pressure of the segments above the fusion, and that it's giving you the outcome that you want, increasing lordosis up top, reducing anterior head translation. So in any case where there's a fusion or anything you're unsure about, x-ray them or send them to one of your colleagues in town that has the capability to x-ray them on a table, supine in the x-ray room. But absolutely, there's expectations that you can help that patient get better, because if not, like those articles showed, they're going to break down further.
Also, from an adjustment perspective, what we've done a lot of with the fusions, both lumbar and cervical, is adjust them standing up. You can put them right up against the wall, double zygomatic contact, have somebody up there. I'm like, Anthony's actually laughing. I'm serious about this. I've got a guy in a walker that used to be a patient. Now he's completely fused surgically, and he came in with his walker, and I put him up against the wall. Actually, Anthony's seen this, and we just get right on to C1 and just adjust. Okay. Or you can actually adjust C1. You can get right onto the shoulder and right on the hip and just stimulate the proprioception. And it just, there's major change that happens. So even though there's fusion there, you can still do, and so standing adjustment is pretty cool. And once you start to see the change, it's like you'll keep it part of your arsenal.
Thank you.
Anyone else that'd like to share or have a question or comment?
So thank you very much again, Dr. Pascal. It was a very amazing seminar.
My pleasure. Thank you.
And also, I like the 10% discount every single time that you offer this webinar, because in the US, we don't get that opportunity, sadly. So that's good.
I can't speak for Dr. Deed.
So I know, but I'm not complaining. I've seen the patients with the post-surgical cases, and then not many times that I see they actually respect those curvature and sagittal lines. Yeah, and a lot of times two cases either they can't do it because too much degeneration happened already, and the other cases they just don't respect the lordosis and the other important aspect that we consider. So how many times, what are the trend right now? If they go to surgery, what are the chances the surgeons will respect those lordosis and try to recover some of it at least?
That's a good question. I can't say that I'm going to give you a percentage, but I'm going to say that there's probably more agreeance in the surgical world in terms of starting to understand this literature, and it's being more accepted than it would be like in the corrective chiropractic. Like if you could put a percentage on corrective chiropractic, who's actually trying to put a curve back into the neck? I don't know, maybe Drs. Yuri and Dr. Ed have a better idea. I would say it's probably 10% of chiropractors. So would you say 10% of spinal surgeons? I'm going to say it's probably above and beyond that. And this is based off of a webinar that Dr. Evan Katz recently did. Like he worked side by side with a spinal surgeon. Like it's literally his neighboring office in Colorado. And he had him, Dr. Chip Cheney, and he was talking about the fact that yes, more and more surgeons are starting to understand this. And as a matter of fact, the future of spinal surgery is going to be robotic surgery. And the robotic surgery, like they're going to literally be able to program into the machine what curve angles they want. They're going to look at all these parameters. They're going to program it into the machine. Boom, the machine's going to go in and fuse the spine on the patient in the proper lordotic position. So I can't give you a percentage, but I can tell you that it's an area in research that's very new, just like for us, we'll say past 10, 20, 30 years. It's growing in the cervical literature, the surgical literature, just like it is in ours. But I think it's going to catch on quicker there because they have fewer naysayers than we would in chiropractic. So that's the best answer I can give you. I don't have exact percentages. It's growing. It's becoming more and more accepted in the surgical arena. And they're getting to the point where robotics are going to be type in the data, boom, the robot does the surgery in a lordotic position.
How about what are the chances that because of too much degeneration already happened in the spine, there are many situations they can't even try to put the curve back in because of it's too dangerous.
Of course. And I mean, the same thing will apply for us, right? When you get a patient that's got, completely degenerated spine, you're going to do the best you can, right?
Yeah.
But as someone in their 70s with tons of DJD, 3 phase 4, are we expecting the same changes as we would, a 40-year-old patient or a 30-year-old patient that can get a great curve correction? So I would say, the same rules of tissue dynamics are going to apply for them as they're going to apply for us. So yeah, it doesn't mean that they can't try and help them, but they're going to be limited because of the degeneration and damage they see.
And some of them won't even do surgery, right? So it gets to the point where they won't do surgery. And that's why the kicker is that's why an 18-year-old hockey player that goes into the board and now has a reversal in his neck, it's serious. Like it's serious. Like
absolutely.
The more we get that, the less we'll see the surgery. And the surgeries are on the rise, which actually blows me away. Like it just blows me away that surgeries are on the rise, especially with what we went through with the 80s and stuff like that. It was just the mess. It's a lot less invasive now, but any surgery, the best surgeons are the ones that don't want to do surgery.
And I mean, that's, again, if you go back, and I recommend that everybody go watch it, because I believe that webinar was free with that spinal surgeon, that neurosurgeon. He says, if he could find chiropractors who do this, he refers his patients to corrective chiropractors because he doesn't want them to do surgery. And, the surgery is the last ditch effort for a good surgeon because of the complications that arise with it. And so hopefully, as this becomes more and more commonplace in the surgical world, and, maybe we're going to develop more of a relationship with spinal surgeons than any other professional as they refer patients to us for conservative reconstructive work.
Sandy, can you hear me? I'd like to go next. Hi, guys. It's Dr. Heidi Benda, North Vancouver, BC, and I just want to thank you, Dr. Pascal, and this includes also Deed Harrison and Dr. Evan Katz, just for your dedication, the knowledge, expertise, volunteering your time. And this is a critical era in what's happening, because what goes down in BC here is a precedence for what can travel around the country and go global. And it's interesting because it's the exact same pathway of the prophecy for Warrior Global. So I just want to thank you in advance wholeheartedly, and just please go fight. I've served on the board 7 years, and there was also something saying, I said, well, I want to get a new digital is what I had said. And one of the exec says, well, you may not want to invest in that yet. And I said, what do you mean? And there was no further comment. So there's been something brewing for some time here that I wasn't able to ascertain. So I want to thank you, and the truth wins. Thank you.
My pleasure.
We're at 1:59. Do you want to take a couple more, Dr. Pascal, or?
I can. It's up to you guys.
We'll take one more.
Okay.
Yeah, we have patients starting to come in pretty soon.
Okay.
So.
And if there's any more questions, you guys just, either fire them through Sandy and Warrior, just get a list of questions and I can type them up and answer them the best I can after. And then we could, email those back out to you guys if we can't get something answered today.
Dr. David Cameron, you're up.
Ready. You may have covered this already, but I was wondering if there's a place where we can find some of this research compiled together, or places where we can reference it. We haven't lost our x-ray privileges here in Alberta, but we are referring some of our patients through family doctors to get their x-rays because of the loss of funding for chiropractors to get x-rays. We don't have our own unit. And we're getting some pushback from some of these doctors as to why it's important to look at the alignment and get these films done in a standing posture and everything. And most of them are open to research and information to tell them otherwise, but most of them are like, I don't see a good clinical necessity for an x-ray right now.
Yeah, I mean, the best place is the website I stated up front, and let's see, maybe I can copy paste it into the chat, but it is called professionallyintegrated.com. And that's Dr. Evan Katz's site, and he has put together a bunch of this literature in a very easy to use format. Here, I'll post his website right there. It's in the chat so everybody can have it. There's a free service. If you want the service that's going to have all of the research, the data, the notes, you're gonna end up paying for it. It is a paid service, but it's fantastic. It is the best up-to-date compiled research data. And what you could do is you could probably just log in at the medical doctor's office and say, here, look through all of this research. There's 200 plus articles here supporting the need for biomechanical assessment of the spine, where spines break down, patients get worse. Basically, the 3 articles I took today were right from Dr. Katz's site. So You know, he's a beast. He's done this over and over. He's been to court numerous times. I think the court case he's won with the highest case visits so far was like 100 and some visits, where insurance companies were naysaying and negating the fact that he needed to do this. Basically, he pulls up his site, those research articles, and he wins almost every single time, because anytime a third party, independent party sees that information, it's hard to argue the fact that, yeah, there's great data there to show that this is absolutely necessary and beneficial to avoid other long-term problems. So yeah, check out that website. That's the best place to get it.
Excellent. Thank you.
My pleasure.
Thanks a lot, Dave. Thanks, Pascal, and really appreciate it. And you know, let's multiply this, guys, across Canada, into the States, around the world. Invite friends, as mentioned. So we're gonna go back and we'll post some old webinars too that Pascal has done over the years. We'll pick and choose. We'll amp it up. And so just go to YouTube channel, subscribe, ring the bell, and so that you guys get notified, because we're not going to release all notifications just across the board, just so we want to make sure that we get the right eyes on this stuff. Okay.
Awesome, everybody. Thanks for being on, and have an amazing day.
Thanks, guys. We'll see you next time.
Thanks, Pascal.